Now we're going to study iron deficiency anemia. Iron deficiency anemia. This is the most common cause of microcytic anemia. Microcytic means that the mean corpuscular volume is going to be decreased, less than 70 femtoliters, or less than 80 femtoliters. Usually would be 70, 72, but the issue is that it's less than 80 femtoliters. So why the patients can have the deficiency on iron? Children, because of poor feeding, decreased intake. Babies or neonates, because there is low iron on the milk, mother milk. So at 6 months of age, the baby needs to be taking iron supplements as well as vitamin D supplements. For middle-aged patients, for women, the most common cause is due to menstrual bleeding, and for men, the most common cause is peptic ulcer disease. For the elderly, the most common cause in developed countries would be due to colon cancer or polyps, and in underdeveloped countries would be due to Necanthor americanus or Ankylostoma duodenale parasitic infections. And these are also very commonly seen, these two in children aged 12, 10, like that they go to the beach without socks and the larva penetrate the skin, migrates through the skin to the respiratory tract. They go to the trachea, up, and sometimes the patient can have a little bit of cough, but then they are swallowed and go into the gastrointestinal tract, and they become locked there and decreases the absorption of iron. So this is very common also in children. Alright, so these are the causes. And other causes include gastric bypass or gastric resection, because we need chloride acid in order to increase the absorption of iron, of heme iron. Also, if there is celiac disease, there would be increase in the vellosities of the duodenum, and so we cannot absorb the iron. Remember, the iron is absorbed in the duodenum, but we need the gastric acid. And other things include malabsorption, etc. Now, sometimes the patient will present with something called the Plummer-Vinson syndrome or Peterson-Kelly. This syndrome is a triad of iron deficiency anemia, dysphagia, and esophageal webs. And sometimes they can also have atrophic glossitis, and so the tongue would look something like bright red or beefy red. Alright, now the presentations would be the presentation of any anemia. The triad would be tachypnea, tachycardia, and pallor of the conjunctiva, of the hands. Specifically in the iron deficiency anemia, the nails have a shape called spoon-shaped, and so this is called coilonochia. This would be very specific for the iron deficiency anemia. Remember, the iron deficiency anemia is a man usually requires 1 milligram of iron a day. A woman in reproductive age requires like 2 to 3, more or less. The capacity of the absorption of iron in the duodenum could be until 4 milligrams a day. Alright, now, when the patient presents with this, the best initial test is certainly the complete blood cell count in order to see the red blood cell, and the iron test. The iron test includes ferritin, percentage of transferrin, saturation, iron, and the total iron binding capacity. So look, because a little bit of the physiology. Remember, we absorb the iron. This is the enterocyte. There's absorption of the iron in the enterocyte through the ferroportin. Through the ferroportin is then sent here to the blood, and the iron is put on the transferrin and goes onto the bone marrow and the liver. So macrophages of the bone marrow and of the liver now contain iron, and the iron is stored with the ferritin. Alright, so now what happens if we have iron deficiency anemia? The iron would be decreased. Certainly the iron would be decreased, and we would be consuming this storage iron, so the ferritin levels would be decreased because we are not storing iron, so ferritin would be decreased. Percentage of transferrin, there would be less transferrin with iron, so would be decreased. And the total iron binding capacity, that is, because there is decrease in the iron that is bound to the transferrin, there is more transferrin that can be bound to the iron. So there are more spaces for the iron because there is decreased iron. So the total iron binding capacity would be increased. And always the total iron binding capacity would be exactly the opposite as ferritin. So this would be what we will see in the iron studies. The most accurate test would be to do a bone marrow biopsy, in which we will see hypochromic red blood cells, etc. But we almost never do that, and we treat the patient with iron supplements. Now, the distribution of the red blood cell wide distribution would be increased because that means, like, if all the red blood cells have the same size, the red blood cell distribution, wide distribution is small. If we have a lot of sizes of the red blood cells, the red blood cell distribution wide is increased. It's kind of the standard deviation from the mean. So here the bone marrow is producing reticulocytes and red blood cells, but because there is iron deficiency, each red blood cell is decreased in size. So we will have a variety of sizes in the red blood cells, and this would be seen as an increase in the red blood cell wide distribution. Also, there would be increase in the a decrease in the reticulocyte. Decrease in the reticulocyte because there is iron deficiency, so we don't have the ingredients to produce red blood cells. So there would be a decrease in reticulocyte count. What else? There would be decrease in reticulocyte count, and sometimes we will see increase in platelets. Now, we always need to test for iron losing by bleeding. For example, if the patient is greater than 60 years old and presents with anemia, that anemia could be due to colon cancer. So a patient greater than 60 years of age with anemia, it is cancer until proven otherwise. So we need to do for elderly patients the the stool-Weyck test, in which we look for occult blood, and if this is positive, we will consider cancer, and we need to treat the cancer as well as the anemia. For the treatment of iron deficiency anemia, we treat with 3 tables of iron supplement a day at the beginning, and then one just table for 4 to 6 months or 2 to 3 months, something like that. The iron supplement can produce constipation, diarrhea, vomiting, nausea, abdominal pain, and black stools. So the sulfate ferrous, that is the iron supplement that we give, can produce black stools, the same way that bleeding from the GI tract can produce black stools, that could be melena. So if the patient presents with black stools after giving iron supplement, this could be because of the iron supplement. But if the patient presents with red stools, that would be hemoglobin in the stools, that is not due to the ferrous iron supplement. That would be because the patient is losing iron through the GI tract, and so in that case would be iron, could be colon cancer. Let's say that we just think that this is a 60-year-old patient, and we think that it's just iron deficiency anemia for whatever reason, and we did not test for the occult blood. So we give the ferrous iron supplement, and if this iron supplement can produce black stools, yes, black stools, and we would not worry about that. But if we see red stools, that would be hemoglobin, and that is not explained by the iron supplement, and so we would have need tested for the occult blood. Sometimes we need to give IV iron. The IV iron would be if the patient cannot tolerate oral therapy, for example in hyperemesis gravidarum or malabsorption, etc. Also increases the quality of life in patients with chronic kidney disease, chronic congestive heart failure, inflammatory bowel disease. And if we give IV dextran iron supplement, that decreases the allergic reactions. And if we give sucrose, it will, instead of dextran, we give sucrose, sometimes can decrease and specifically the allergy to that supplement.